Hi and welcome back to another video of Medic Notes. This video will be on endotracheal intubation in pediatrics. The indications for this procedure is to provide mechanical respiratory support, or when the back and mask ventilation or CPAP is insufficient, to alleviate upper airway obstruction such as subglottic stenosis, direct suctioning of the trachea in newborns to clear the meconium from the trachea, diaphragmatic hernia, because in these cases, back and mask ventilation are contraindicated, and to administer medications in the emergency setting before intravenous access is established. This is the list of equipment needed for this procedure, which are endotracheal tubes according to appropriate size, laryngoscope, blades with different sizes. 00 is for extremely preterm babies, 0 is for preterm, size 1 for full-term infants, and size 2 for children. Back and mask apparatus with high flow oxygen. Malleable stylet is optional. Suction apparatus, scissors and adhesive tape. Pulse oximetry and electrocardiogram monitor to monitor vital signs. Personal protective equipment, sedation and muscle relaxant are optional. This is the table showing the different ETT size according to different weight of the babies. So bigger babies or children will use a larger size, and the depth of ETT insertion will be deeper as well. Starting off with the procedure, place the infant in a sniffing position with the neck slightly extended. It is optional to put a small roll behind the neck as it may help with positioning. And take note to avoid hyperextension of the neck to avoid tracheal collapse. Cautiously suction the oropharynx as needed to make the landmarks visible. Next, pre-oxygenate with a back and mask ventilation until well saturated, and monitor the heart rate, color, and pulse oximeter. However, we have to omit this step in a cardiac arrest child. And to avoid hypoxia, limit each intubation attempt to less than 20 seconds before reoxygenation. Throughout the procedure, we have to monitor the child's vital signs. Insert the laryngoscope blade into the right side of the mouth and sweep the tongue to the left side. Stabilize the head and hold the mouth open while performing this maneuver. Next, we advance the blade a few mm, passing it beneath the epiglottis. Lift the blade upward and outward to elevate the epiglottis, and then we can visualize the vocal cord. Next, pass the ETT tube along the right side of the mouth and down, passing the vocal cords during inspiration when the vocal cords are open. And we may need a stylet during this process. After intubated, remove the laryngoscope and hold the ETT tube firmly with the left hand. Connect it to a self-inflating bag and positive pressure ventilation. We can confirm the position of the ETT tube by looking at the chest expansion, listening to equal breath sounds on the chest, and auscultate the stomach. Paint the skin with tincture of benzoin and secure the ETT tube with adhesive tape. Connect the ETT tube to ventilator or resus bag. Insert the orogastric or nasogastric tube to decompress the stomach, and we can perform a chest x-ray to confirm the position of the ETT tube. So there are a few complications that might occur after this procedure, which include upper airway trauma, perforation of the trachea or esophagus, improper tube positioning, laryngeal edema, tube obstruction or kinking, infection, palatal grooves, or subglottic stenosis. That's all for this video. Thank you.